Electrocardiography was invented more than 130 years ago. During that time, there were giants of medicine who explored completely the method, and there was nothing new to discover. But in that moment, authors had to work with analogic signals. Measurements were difficult and manipulation of the records impossible. Today, the progress of the technique has allowed the digitization and storage of data, its recovery, and the possibility of carrying out different manipulations and measurements on them, even in cases stored in databases. The possibility of accessing the simultaneous measurement recorded by the ECG electrodes has allowed us to create a series of new electrocardiographic methods that, based on the information produced by a standard 12-channel electrocardiogram, provide detailed information on the electrical activity of various parts of the heart. This new method consists in the creation of precordial bipolar leads, weighted unipolar leads, regional vectorcardiograms, and polar coordinate representations. Precordial bipolar leads, PBL. This method is based on a simple subtraction of voltages of two classical unipolar precordial leads. This subtraction results in an electrical vector directed from one electrode to the other, creating an axis perpendicular to the one represented by the primitive precordial unipolar leads. So, the creation of the PBL B2B1 is the existence of an electrical vector right to left, perpendicular to the vector formed between the central terminal of Wilson and the PUL B1 and B2, posterior anterior. The combination of the 6 classic PUL allows the creation of up to 15 PBLs that show the electrical activity of the heart from a different perspective, magnifying the phenomena closest to them and minimizing those that are outside the area covered by the lead. So, all the PBLs created between B1 and B4 explore the right-left axis of the heart, while those formed between B4 and B6 explore the anterior-posterior axis of the heart. The proximity of the precordial electrodes to the myocardium allows to obtain tracings with a much better signal-to-noise ratio, and therefore quality. PBLs created from PULs. This slide shows in panel A the representation of a standard 12-channel electrocardiogram, and in panel B the same 6 precordial leads of the same electrocardiogram, with the difference that in panel A the amplitude standard is similar for all the tracings, and in panel B it's different because an attempt to achieve a better visualization of the trace, even sacrificing the amplitude comparison between the traces. Panel C presents the 15 PBLs that can be obtained from the electrocardiogram of panel A. We have decided as a convention that the leftmost electrodes, or with increasing numbering, will be taken as positive. Therefore, the PBL B6, B4 normally present an important Q wave representative of the anterior initial direction of the cardiac depolarization vector. Contrary to what happens in the standard electrocardiogram, the PBL B2-B1 shows that the initial vector of the QRS is directed to the left and not as we are used to seeing in the classic electrocardiogram to the right. The panel D on this slide takes as a reference the ABF lead and use of different PBLs to build different loops in the frontal plane. In this case, the PUL-B1 has been used as the negative electrode of all the PBLs, and B2, B3, and B4 as the positive ones. This allows demonstrating the modification that can occur in the loops when the amount of cardiac tissue under the recording of the electrodes increases. As it can be seen, the PBL B2-B1 reflects the electrical activity of the interventricular septum and right ventricle. This characteristic is very important to study of anterior wall infarction. PBLs and weighted leads. The manipulation of the same data that produce the PBLs allow creating weighted unipolar leads. These leads are simply the proportional sum of two classic PULs. Generally, 50% of each lead is used and the lead obtained is located in the middle between the original PUL. The slide shows in red how the average of B1 plus B2, B4 plus B2, and B4 plus B6 are formed. In blue, it can be seen how the PBLs are formed. This slide shows four tracings that reflect the right to left axis, and they are standardized to the same electrical amplitude. As it can be seen, the bipolar precordial lead B6-1 presents higher amplitude and less signal-noise ratio than the other tracings. Weighted leads. As it was mentioned before, weighted unipolar leads are a combination of two standard pool leads in different proportions. We use the average WL 50% of each pool because this lead is perfectly perpendicular to the PBL, and this allowed to create sectorial electrocardiograms representative of the region between both electrodes using the average pool and the corresponding PBL. In theory, in a normal patient with the electrodes positioned correctly, the average of B2 plus B4 should be equal to the recorded B3 pool, and the average of B4 plus B6 equal to the recorded B5 pool. In fact, the correlations that we have obtained in normal patients are extremely high. In pathological patients who presented anterior infarction with amputation of the R wave from B1 to B4 on patients with LBBB, then the comparison between computed B5 and recorded B5 could alert about electrical abnormalities or electrode misplacement. Regional electrocardiograms. As we have shown in the previous slide, the combination of the standard or weighted unipolar leads with the PBLs allows to create sectorial electrocardiograms representative of a portion of the myocardium to be studied. In our work, we have concentrated on the electrocardiograms that are obtained in the horizontal and frontal plane by combining the B2-B1 PBL, the average B1 plus B2 pool, and the standard ABF lead. This combination has been especially useful to us because the B2-B1 PBL reflects the retroexternal electrical activity and is extremely sensitive to the distortion due to ischemia of the interventricular septum or ischemia of the right ventricle. The existence of one of these two anomalies exaggerates its representation in this lead. Sectorial BCG disaggregated. This slide shows how the regional vectorcardiogram is formed. Panel A shows the average B1 plus B2 pool in red. The x-axis shows the time and the z-axis shows the electrical amplitude. In panel B, we can see in blue the PBL B1 B2. In this case, the x-axis shows the electrical amplitude and the z-axis shows the time. Panel C shows in the transverse plane the regional vectorcardiogram of the retroexternal area. This vectorcardiogram is the result of panel A and B. Panel D shows all the information by the addition of panel A, panel B, and panel C. Regional retroexternal vectorcardiogram in 18 controls. In the next 3 slides, we will see, to have an idea, the common loop in 18 controls. As you can see, the shape of the loop is oval, and the first portion is going forward and to the left, and the final portion is directed to the right and backwards. As we will see later, this will be important in diagnosis of electrical pathologies of the heart. Comparison of standard BCG versus retroexternal regional loop in acute anterior infarction. As we mentioned before, in the anterior wall infarction, this derivation is especially useful. The slide shows a comparison between the classical transverse vectorcardiogram produced with the X and Z leads and the vectorcardiogram produced with the B2, B1, PBL and the average B1 plus B2 pool. In panel B, it can be seen what we call the beaten apple sign, which consists in a concavity to the right of the initial part of the loop. This concavity represents the imbalance of electrical forces between the interventricular septum infarct and the right ventricle healthy forces. Since there is a predominance of the forces of the right ventricle due to the absence of the most powerful forces of the septum, the vector abnormally turns to the right. As we will see later, an anterior infarction can present 3 patterns in the transverse retroexternal vectorcardiogram. Pattern 1 is a QS pattern. Pattern 2 is an initial pathological Q wave. And the pattern 3 is the beaten apple sign, in which the beginning of the bipolar R wave is truncated by a change of the vector direction to the right and a posterior return to the left, giving that particular shape to the loop. A 49-year-old male with an anteroseptal myocardial infarction of 24 hours of evolution. We can see in this slide the conventional transverse vectorcardiogram, and in panel B, the transverse retroexternal vectorcardiogram. The PBL B2B1 shows a QS pattern indicating an anterior wall infarction. Sectorial retroexternal vectorcardiogram and hyperacute ischemia, RCA occlusion. Panel A shows the pre-ischemic vectorcardiogram, and panel B shows the post-ischemic vectorcardiogram. The polarity of the ABF S wave is inverted, amplifying the R wave. The ABF R wave suffers a delay from 52 milliseconds to 77 milliseconds. This R wave peak, which at baseline was between the R wave and the S wave of the PBL, in ischemia occurred after the S wave in the PBL B2B1, inverting the loop and pull it down. The inversion of the ECG waves explain the ischemic folding that the QRS presents in the ischemic sectorial BCG. This inversion also causes the ST segment shift in the PBL B2B1 and ABF lead, displacing the J and causing the omega sign. This new method allows to observe that since QRS prolongation is not observed, it is interesting to speculate that these alterations, as well as the subsequent ST change, could be due more to electrical potential differences than to intramyocardial ischemic conduction abnormalities. Electrical cancellation. This slide shows a current of injury to the right in the B1, B2, PBL, and a current of injury to the left in the left pulse. Since this current of injury have contrary direction, they may result in electrical cancellation in the 12 leads standard ECG. Ischemic arrhythmia. This slide shows the onset of an ischemic ventricular arrhythmia after balloon inflation in the proximal LAD. Panel A shows the last normal beat and the first beat of the arrhythmia, green arrow. In panel B, the first 400 milliseconds were deleted to more clearly see the onset of the arrhythmia. The twin arrows show the coincidence in time between the negative deflection and the B2B1 PBL and the onset of the arrhythmia. Panel C shows the tracing of the classic B1 pool and that of the B2B1 PBL. Panel D shows the standard ECG. From top to bottom, leads B1 to B6 and leads 1, 2, and 3. Ischemic arrhythmia detail. Same patient. The onset of arrhythmia as viewed from different regional BCGs. The first 393 milliseconds and the last 350 milliseconds of the QRS loop have been removed to show the arrhythmia onset. Panel A, PBL B2 B1 versus average pool B1 plus B2. Panel B, PBL B4 B2 versus pool B3. Panel C, PBL B6 B4 versus pool B5. Panel D, PBL B2 B1 versus standard ABF lead. The initial tracing shows the last 15 milliseconds of the normal beat prior to the arrhythmia, which begins at 408 milliseconds. In the three panels of the transverse plane, the vectors at the end of the normal beat and at the beginning of the ectopic beat are almost identical, but of opposite direction. While in the frontal plane, panel D, there is a U-turn with the normal part slightly more caudal than the abnormal. It should be noted that when the observation point changes from panel A to panel B, a specular inversion of the tracing is produced. In panel C, observing the phenomenon from the lateral aspect PBL B6 B4 versus pool B5, reduce the tracing of the beginning of the arrhythmia to 1 point. Although polar coordinates locate the position of a point by the angle and the magnitude of the vector, they can be shown as a simple circular representation of the ECG. A circle is used and some or all the leads of a plane are represented superimposed. We will see that in the next slide. It allows detecting phase shift among them that are difficult to appreciate in the standard 12-channel ECG. Polar coordinates in normal ECG. Panel A shows a cardiac cycle in a control patient. Panel B shows a magnification of the precordial QRS waves. WPW patient. Pool tracings A V1, B V2, C B6, and circular ECG D transverse E frontal in one patient with pre-excitation and abnormal ventricular depolarization. The comparison with the image of the previous slide shows an abnormality that we will see in more detail in the next slide. Polar coordinates in a patient with WPW. Circular ECG in the transverse plane in one patient with pre-excitation and abnormal ventricular depolarization. Superimposition of the precordial leads demonstrate two independent waves of depolarization. The stimulus first passes through B6 pool 205 milliseconds in coincidence with the delta wave in V1 pool. In the second part of the QRS, a new wave of depolarization appears in V1 and V2 pools. V1 pool R wave peak occurs at 296 milliseconds, 91 milliseconds after V6 peak. Besides, V6 pool repolarization is posterior to V1 and V2 pools repolarization. Polar coordinates in patients with RBBB. In patients with complete RBBB pattern, the comparison between pool V2 and pool V1 shows that V1 pool R wave is delayed in relation with V2 R wave. Polar coordinates in patients with LBBB. In patients with complete LBBB pattern, the comparison between pool V6 and pool V1 shows the V6 QRS delay wave with the typical plateau. Conclusion. Even though electrocardiography is more than 130 years old, this new method shows that the old ECG holds many undiscovered secrets. If doctors and researchers could access its raw data, a new dimension to study cardiac electrical activity would open for everyone.